Hi, good afternoon. Thank you for joining me this afternoon. The title of my presentation is Kinematic Characteristics of Postural Stability During One-Leg Standing in Athletes. The most common etiology of spinal injuries in sporting activity are improper mechanics and overuse that adversely affect the stability of spine. So spine is the engine of movement, and I believe somehow we can understand spine mechanics better. So these mechanical forces may cause instability of the spine through disruption of spinal support and mechanisms. So when you see various activities like running and cutting, or just tennis ball play, and lifting and moving, and also some other activities, all those activities actually related to one leg standing and some balance issues. So the altered coordination within the lumbosacral complex might be a compensatory response to protect the connective tissues from additional pain or discomfort. And such differences have the potential to contribute to variation in kinematics and coordination of the lumbar spine. So as you see this picture, monkey doesn't have any back trouble because there is no any mechanical stresses go through this spine. However, the human being, a lot of bad postures and some alcohol and some mechanical stresses generates a lot of problems. So bad posture with sustained movement, that is the main thing. So mechanical stresses that we need to really understand better for the spine care. One of my important messages is pain is important. Pain is the main cause to see physician or therapist or clinicians. But the source of pain is dysfunction. So dysfunction is the actual source of the pain, and this is the altered mechanics, either increase or decrease from the expected normal, or the presence of an aberrant motion. So based on this concept, I thought about this evidence-based practice. So evidence-based practice is the integration of the best practice research evidence with clinical expertise and patient values. And it should be patient-centered clinical research. That means we do not doing this evidence-based research to justify what we are doing, but for patient's sake. We would like to provide better outcomes with sensitive tools to show the difference of the important outcomes. So evidence-based practice is related to many other things. Patient preferences are obviously important. And research, which should be clinically related. I don't like research for just research, but this research should be applicable and practical to help people. And clinical expertise and knowledge is very important, and also resources. All those things are important. So low back pain is my main interest, and prevalence is 60 to 80%, and 85% of low back pain is non-specific or functional cause that relate to posture and balance, and eventually quality life is a trouble. So we like to do some kind of evidence-based research to improve quality of care. Musculoskeletal system is one large kinetic chain and alteration in orthostatic and dynamic posture, but this is for the both stability and mobility needs. So this multi-segmental contribution comes through the bone, joint, capsule, ligaments, and so on to provide force attenuation, transmission, and absorption. The title of my research is a kinematic and kinetic analysis of spinal lesions in athletes with recurrent low back pain during one leg standing. The purpose of the study was to evaluate the relationship between normalized kinematic and kinetic stability indices, especially for spinal region. That means lumbar spine, thorax area. And considering visual conditions during non-dominant leg standing between athletes with and without recurrent low back pain. So this is the tool that I use, one leg standing. It could be, we can use visual block, and also we can ask the patient to stand on dominant side or non-dominant side. So I developed a model like this from motion analysis. So the green thing is here is the core spine model that I looked. And there is behind this blue-green thing, there is a lumbar spine, lower thorax, and upper thorax. Methods. The normalized kinematic stability indexes for spinal regions, and also I compared with kinetic stability from force plate. So if someone's stable on the floor, it should be more stable on upper part, but we would like to know what's going on between this from force plate to the spinal region. So all participants were asked to maintain non-dominant leg standing with a dominant hip and knee flexed approximately 90 degrees for 25 seconds. So 42 participants attended this, 22 people with low back pain, and 20 control groups. So this is the identification of successful holding time and standstill time. So this is important measures that I'm using. I asked patient to stand for 25 seconds, but first 5 seconds I didn't really use this data. But during 20 seconds, some people stand only 10 seconds, or some people stand 20 seconds. But during this requested time, the successful holding time is the 1. So the ratio between requested and the successful holding time should be 1, a person doing correctly for 20 seconds. And at the same time, I measure the rotation X, Y, Z from the lumbar spine, lower thorax, upper thorax, and also core spine. So next slide will show you a little bit better. So again, relative holding time is the successful holding time and request holding time, the ratio between this. And relative standstill time is the standstill time divided by successful holding time. Next picture actually shows you better here. Now this one is relative holding time. So 0 to 1. I made this index to explain a little bit easy concept for people in clinical field. So if relative holding time is 1, then this person, number 25, this person was able to stand within 20 seconds. So 20 seconds for standing, for holding time 20 seconds. That should be 1. Now next person, number 28, when you see this person, this one was able to stand for 20 seconds, but as you see this kind of fluctuation, I cut this threshold and I count this lower part. That's for the standstill time. So number 28, the person was stand for relative holding time was 1, but this person was able to stand just within this threshold about this much, about 25%, 30% of the whole this trial. Number 18, this person could stand only for 5 seconds or so. So relative holding time is really short, but relative standstill time is good. So that's number 18, and so on. So this is clear, I think. This is only for the kinematic from the lumbar spine area. Now, kinetic index is similar kind of concept. Let me show you one more thing. Okay, here, let me show you this one. So this is kinetic change from the force plate, Fx, Fi, Fz. The ratio, the formula is based on the vector concept. So the raw data minus the x average and the square of it, and Fy and Fg and so forth. So this is successful holding time, standing time here. This is from the force plate, but this is from the rotational moment from the spinal regions. So this is interesting thing that I'd like to show you. This is the patient with low back pain. This one is control group. So as you look at this, kinematic index from the force plate is 1, and kinematic stability of head 1, then this is the best. So the black dot is blinded condition, and the open dot is unblinded condition. So as you see, the blind eye open conditioning is really important. But I would like to ask you, focus on spine 1. This is lumbar spine. This is lower thorax, upper thorax, and core spine here. So let me explain this core spine a little bit. I would like to focus on core spine and lumbar spine region, these two. So as you see the patient and normal group, the normal group, the fluctuation is more focused on 1 and 1 here. But patient is spread out all over here. So the core spine is the pelvic plane here, pelvic plane from S2. This is pelvis, this is trunk, and this is core spine. Core spine is perpendicular of this pelvic plane from S2. The lumbar spine is connected from thorax and pelvis. Now, I'd like to really differentiate this lumbar spine and core spine, because many people are talking about core spine activity, but we really cannot measure core spine because it's so deep. We cannot put needle in there, and also we really don't know where the core spine is. Probably around lumbar spine area. But I made this core spine to compare with lumbar spine mechanics. So this is the key concept that I would like to show you. The lumbar spine, lower thorax, upper thorax, and core spine here. Patient and control group are different, especially in eye closed condition. But eye open condition is not much difference. So that means during eye closed condition, the person may rely on proprioceptor, especially core spine or lumbar spine area or pelvis somewhere. But when you look at this carefully, lumbar spine has both low back pain and control group high, but core spine here is a little bit different. So this is very interesting stuff that I'd like to keep asking myself, what's going on here? Now, my interpretation for this data is core spine is really depends on this back pain, but lumbar spine is not so much compared to core spine. So my interpretation, the lumbar spine is more closer to the center of mass, or core spine is not so much. So that's what I'm debating now. But during normalized kinetic index from the force plate, we can see big difference, significant difference in eye closed condition between people with and without low back pain. But in eye open condition, not so much difference. So somehow there is something going on between kinetic and kinematic index. So the results For the normalized kinematic index for stability, the visual condition is significantly different, and also spinal region, lumbar spine area, is really different than other areas. And post hoc test result indicated only lumbar spine demonstrated significant difference with upper, lower, and core spine. And also normalized kinematic stability during eye closed condition significantly decreased in low back pain group compared to control. So my interpretation and clinical relevance. The people with low back pain in athletes demonstrate higher lumbar spine stability in eye closed condition compared with eye open condition. And also this higher stability of a lumbar spine might be related to central mass. This is my interpretation. There is no any objective measurement on this, but higher stability is going on lumbar spine area. And therefore, clinicians need to consider both kinetic and also kinematic stability while considering visual condition for postural stability in people with low back pain. So that's my presentation. Thank you. Any comments?